first of all, thank you very much to the Institute for Public Health and for all the colleagues for inviting me to join you today. I'll try to keep this as brief as I can. Hopefully, you're seeing the first slide there. So yes, so this is me. I was a news journalist for many years, but as Roger said, I've been involved in the world of counter misinformation for a decade and a half, just about. The reason I became interested, the reason I became concerned by the effects of misinformation, it started with the effects of observing the effects of misinformation on public health in Nigeria, where I was a journalist at the time. This is in the early 2000s. The effects of misinformation, both on public understanding of health issues and public health policy. In the case of Nigeria, it was leading to a ban on a vaccination campaign being led by the WHO and UNICEF, an anti-polio vaccination campaign. And the ban, the public policy, the change in public policy that the misinformation led to, saw a surge in the cases of polio across the whole of the African Sahel region, leading thousands upon thousands of people to suffer the effects of polio into the long term. Misinformation, I think that the best ways that I know to think of this, I think that there's been so much concern expressed since, broadly speaking, since 2016 about misinformation effects. And it almost always focuses on the effects of misinformation on public understanding. And there are some good reasons for that. I'll come on to why I think there are broader issues as well that we need to address. Evidence that we have from the last 10 years, from years before that, is that misinformation put out into the public domain, whether that's by corporations, whether that's by private individuals, whether that's by interest groups, whether that's intentionally as misinformation, intentionally as disinformation, or unintentionally as misinformation, leads to public health effects. And just to give you three ways that this happens. One is that the take-up of harmful treatments, the harm that is caused directly. There was a very good study. There are, I believe these slides will be made available later, and there are links in the slides that are shown there. 700, more than 700 people died in Iran after false claims spread in that country in the early days of COVID that alcohol could be used as a cure for COVID. Through to, this is a study that I did looking at promotion of the use of diluted battery acid as a treatment for conjunctivitis in Nigeria. It's a long-standing myth in West Africa that battery acid can be used in this way. It obviously leaves the people who use it blind, and there are hundreds of cases every year of people going into ophthalmologists in Nigeria and countries around, having taken up this myth, which is now spread on social media platforms. So harmful treatments taken up that have a direct harmful effect on people's health. The second main way that harms happen, that people most commonly talk about, in fact, when they think about this, because people think, when you talk about health misinformation, people primarily think in terms of vaccines, which is an important area, but it's not the only area, as I'll go on to say. So harmful treatments taken up, beneficial treatments rejected due to sort of ill-founded, exaggerated fears. Vaccines is a case in point. Also then to ineffective treatments taken up because of a false belief that it's as effective or more effective than an effective treatment. So studies going back to, there's a famous study going back into 2014 showing that a so-called healer promoting an ineffective treatment for HIV/AIDS, the treatment that was being offered wasn't directly harmful, but people who took the ineffective treatment then stopped taking more expensive treatments, and ARVs and so on. And so it was the false belief in an ineffective treatment led to a downturn in the take-up of an effective treatment. And so harmful treatments taken up, beneficial treatments rejected. A third way that individuals and members of the public can be affected by health misinformation is people failing to understand or misunderstanding what will cause their health behaviors that will make them put them at risk of diseases or other health harms. So misunderstandings about disease causation, transmissibility, means of transmission, susceptibility, and so on. So this can be the false understandings about different people of different age groups being vulnerable to particular diseases, people of different ethnic backgrounds being vulnerable to particular diseases, of how diseases are passed on, how they're how transmissible they are, and so on. And we saw that in COVID, and we've seen that in many other instances. When individuals, I was interested in hearing the earlier presentations and the how frequently the problem of corporate influence of the health harms that can be caused by the food industry and all the other industries that Anna and Nora were talking about, and the responsibility for this is very often framed as an individual responsibility. And it's about, your choice to take the Coke, or it's your choice to do this and that and what have you. The reason that I became interested in the effects of misinformation is going back to seeing the effects of misinformation on a polio vaccination campaign. Authorities in Nigeria in the early 2000s, when I was there, banning polio vaccination, which led to thousands of people contracting polio. We saw, and the effects that has on public health when the misinformation affects public policy directly can very often be far greater than when misinformation affects the behavior of individual members of the public. And it does that in a number of ways, pardon me. It does that in a number of ways. So you see those three there. So the first is misallocation of resources and treatments in the public through public policy. So in Kenya, a lot of my work, as we were saying, has been in Africa, but these models, these effects are identified around the world. In Kenya, officials have refused to endorse the tetanus vaccine because of misinformation that you can trace back to a misreported academic paper from the 1990s in India. And as a result, Kenya has one of the world's highest rates of tetanus infections through around the world. The ban on polio vaccination that I mentioned in Nigeria, the misallocation of treatments in around COVID in the United States, also in Brazil, also in Madagascar and elsewhere, and so on. The many cases around the world where public health policy during COVID was affected by misinformation affecting the decisions of policymakers and practitioners and others. Policymakers don't only misallocate resources and treatments due to misinformation, they also promote ineffective treatments. So we saw in South Africa in the early 2000s, an academic paper was produced in the US in the 1990s, suggesting that HIV was not the cause of AIDS. This changed public policy in South Africa. President Thabo Mbeki accepted this academic paper, which is a very flawed academic paper, changed public health policy, and the government started promoting the use of beetroot as a cure for AIDS. And the net result of the change in public policy in the early 2000s, according to research done so two studies, one in South Africa, one by South African academics at Harvard, I think it was, showed that there were 330,000 to 350,000 excess deaths in South Africa in over 6 years in the early 2000s due to this change in public health policy, stopping the promotion of ARVs and promoting ineffective treatments like the taking of beetroot as a cure for AIDS or a cure for HIV. There are studies in the EU showing that in the 2010s, the promotion in medical guidelines of the use of beta blockers as a pre-surgery treatment may have contributed to thousands. Some studies suggest tens of thousands or even hundreds of thousands of excess deaths in the 2010s. The promotion of ivermectin for COVID in half a dozen countries around the world during the COVID outbreak. So misallocation of resources and treatments, people failing to provide effective treatments and resources that were needed, policymakers promoting ineffective treatments, beetroot or beta blockers or ivermectin and so on, dismissal of real risks and dismissal of real treatments. So the dismissal of COVID risks in the US in 2020, dismissal of the effectiveness of vaccines in general at the moment, as we're seeing. If we're going to think through, so there's been, as I say, roughly speaking, since 2016, interest in the effects of misinformation on public health and on wider society has grown and grown and grown. In order to understand the way it works, I think it's helpful to understand the misinformation effect in fundamentally in two ways, but that can be then broken down into three. So one is what in medical terms you might call the acute phase of misinformation. So it's the potential for the direct effect of factually false information on individuals' actions or decisions. So this is false information on a health topic where the audience has capacity and may be motivated to act on that false understanding then or soon. So that audience may be members of the public. It may be individual policymakers or practitioners. In the case of that I mentioned earlier, the false information spread in academic journals that HIV wasn't the cause of AIDS had a very, very small population audience in South Africa in the early 2000s. Unfortunately, one of those who saw it was the president of the country, and he had the capacity and was motivated to act. He believed the false claims, changed public health policy with disastrous consequences. In addition, so that's information that that the audience has capacity and motivation to act on at that time, then or soon. A lot of the way that misinformation affects public behavior and policy formation is not through the potential for people to act on it directly as a result of the factually false understanding. It's through its cumulative effects. So it's false information that is repeated over time on a health issue. In this case, it can be on social issues, it can be on economic issues, political issues, influencing our understanding or attitude over the long term. The field of media studies has demonstrated, going back to the 1920s, that the way that public information shapes our understanding is complex, and that attitudes that the attitudes that we have tend to be slow to change. And so presenting somebody with factually false information, somebody who firmly believes in vaccines, let's say, that they firmly present them with one piece of false information about the effects of vaccines isn't going to change their attitude to that issue. But we also know from studies going back to the 1940s, back to the Second World War, that information that is repeated has a much greater potential to be understood to be true. And so through its cumulative effects, recognizing a narrative that is building, not specific false information, but a narrative that is building about the effects of food, about the effects of medication, about the people that you can, about the actions of health authorities. These may be things on which we have no particular capacity and motivation to act at the time, but they shape our attitudes and our understanding over the long term, on which we can then act in future. That cumulative effect, it has potential for effects on our health, but through the effects on factual understanding around health issues, but also on our wider understanding of information, what information we can trust and who we can trust in society. And these can be shown to have effects on public health. So studies done during COVID showed that people who believed that there was more misinformation or disinformation in circulation in general, or people who were more exposed to misinformation and disinformation in general, were less inclined to trust health workers, to trust health guidance in ways that changed, and this changed their health behaviors. So the mis or disinformation that people are seeing, and or the misinformation that they believe is prevalent, undermines our general trust in information in public, and undermines our willingness to accept public health guidance and to turn to alternative sources for information. I was struck in Roger's opening remarks by the figure that he presented from the WHO about the number of deaths per year being caused by by what we're talking about today. One of the challenges, I think, for the newer field of mis and disinformation studies is that we haven't had to date a good means to understand in a similar way the scale of effects of mis and disinformation in general. So there've been particular studies around particular events, and we can demonstrate that mis and disinformation have effects both by their effects on public behavior and by their effects on public policy and on practitioner decisions and practitioner policy. And we can demonstrate that through these, so the studies I mentioned of the change to public policy in Nigeria around banning a polio vaccination campaign. We can demonstrate it by the change to public policy in South Africa, stopping the provision of antiretrovirals. We can demonstrate it by effects of public policy during COVID. We can, you can look at the studies done of the way that individuals take up, based on a false belief, the idea that you can use diluted battery acid to cure conjunctivitis. But there isn't an overall demonstration. There isn't data. We don't have data so far to date demonstrating clearly a causal link between exposure to false information and the scale of the exposure of false information, and providing us with the sort of numbers that Roger mentioned earlier. So as Roger said, I've been working for the past few years, coming from a fact-checking background, on trying to understand how we can do this and how we can seek to estimate, understand the difference between false information that is out in circulating in public, that is inaccurate or is even substantively false, but has very limited potential to cause or to contribute to a substantive consequence or harm, and false information that does have potential to cause real-world effects, real-world harmful effects. And the part of the reason for that, trying to do this, is when there is so much misinformation in the public domain, when people are exposed to that on social media platforms, which is what people think about in general, also in traditional media, also in the packaging of products, in conversations, but then also, as I've discussed, in academic papers presented that present false information. Everybody thinks about the false links being proposed between MMR vaccine and autism many years ago. How we can distinguish and therefore focus the efforts to combat harmful misinformation better in a way that allows for freedom of speech, but recognizes what is harmful. I've developed this model. I can go into detail on it later in questions if that's of interest. It is much more complicated than it's presented there, but so in summary, the model asks, if a claim is presented, a factually based claim is presented, it asks the researcher, the fact checker, to first of all ask, is the claim substantively false? Or does it misidentify accurate information as false? And if the answer to that is no, then if the effect it has, if it's only narrowly inaccurate, and the effect it has on understanding is not substantive, then it doesn't have a potential to have, it can have potential for other effects, it doesn't have a potential for a misinformation effect. If it is substantively false, and it is perceived to be true or sufficiently likely to be true by a sufficient number of people to cause or contribute to a consequence, then it has a potential for, may have a potential for effect. So to break that question down a little bit, different types of false information on different types of subjects require different numbers of people to act in order to cause a consequence. If one individual, if you want to swing an election through spreading false information, in general, you need to persuade thousands or tens of thousands of people to change their actions, change their voting intention, their decision to go and vote or who they're going to vote for, in order to affect the outcome. But misinformation about a health product, saying that something that is dangerous is safe and an effective health treatment. You only need to persuade one individual for that to have an effect. So first question, is the claim substantively false? Second, is it seen as true or sufficiently likely to be true for sufficient people to act on it, to cause the consequence? And the third question is, do those who see it and believe it is false, do those who see it and believe it to be true have the capacity and motivation to act on it in a way that will cause the specific consequence? If it meets all of those criteria, then the claim does have, we're not saying that it definitely will, you can make a clear case that the claim does have a substantive potential to cause or contribute to a substantive harm, a real world harm. We did a trial of this last year, and what this enabled us to do was produce, I won't go through, I have slides and slides and slides of these, of what the data that we produced. What it demonstrated was that of what the research community was looking at, what the fact checkers were looking at, 57% of the claims that people were looking at that were substantively false had no substantive potential to cause or contribute to a harm. 43% did. That indicates that we need to be focusing our efforts more on identifying what is potentially harmful and focusing our efforts on that. First point. Second point is that when we looked at the way that those harms would occur, in 45% of cases where we identified information as potentially harmful, we identified that as being something that would be, in medical terms, you'd say was an acute risk. So it's a false information people have a direct capacity to act on at the time. 55% of those, it was false information that has the potential to shape understanding over time. And the significance of that is that you respond to those different threats, a direct effect and a long-term cumulative effect in different ways. You respond to a false narrative with a counter narrative. You respond to direct false information with factual information that can correct the false information, or with regulation, as I've been saying in the earlier presentations. I'll try to keep this brief. So I talked with colleagues, Dr. Orna Young, who is going to be on the panel later, I think, with colleagues who work on fact-checking health issues in the UK more broadly, about what we're seeing, because this is an evolving field. It's a rapidly evolving field. So vaccines comes up all the time, but there are many health topics on which people see false information. All sorts of false misinformation around cancer, around diabetes, diets, wellness activities. So just on cancer, biopsies are unnecessary, sunscreen causes cancer, cancer is contagious, extreme diets can cure cancer, and fake treatments can boost the immune system. So that's just in cancer, but then, as I say, seeing it very commonly identified across all manner of conditions, and very often with a link to something that is in the news, very often with a link to celebrities. And now with AI, we're seeing people being presented, fake videos of AI-generated videos of well-known personalities promoting particular false understandings. One of the ones that seemed to me to be the most upsetting to me was seeing the late Michael Mosley being a fake video of Michael Mosley presenting a fake treatment. So broadly, the range of topics on which health misinformation is spreading, is growing, is a first trend. The anti-science movement. This is we've been talking about the commercial and political factors here. The anti-science movement, which is undermining belief in everything that I think this conference is seeking to do, is being welcomed and platformed by anti-establishment politicians in the US, in the UK. We've seen that recently at political conferences in the UK. We see that in the US administration and so on. So that's a really significant challenge. And the third point, and we were talking earlier about how this is being presented to young people also, health misinformation is increasingly being aimed at the young by TikTok and other sort of short form platforms. What can be done about any of this? One of the first things I always say, this is a colleague, Professor Tom Rosenstiel. Misinformation is a problem that has existed since humans started communicating, and it's not something, having worked in fact-checking for quite a number of years now, we keep on being asked about when we're going to fix the problem. It isn't a problem we can fix. It's a social condition like crime that you need to constantly monitor and adjust to. It also takes us a Swiss knife approach, I think, to seek to monitor it and to respond to it. Broadly speaking, what works? Nora was talking about education. Education is fundamental to education in media and information health literacy is fundamental to countering the effects of misinformation on public health. They do that very well in some countries. Nordic countries and the Baltic countries do very well in media and information literacy. We do much less well in the UK, and the stats would suggest the same is true in Ireland too. Health literacy in schools improves people's skills at picking this out. Second thing is greater and better access to accurate information. So public health communication, not simply identifying what is false, but identifying what is accurate information, is a fundamental part of the way of doing this. Fact-checking. So Dr. Young from Fact Check NI is on the panel later. There are fact-checking colleagues in the Republic. And there are studies that demonstrate that fact-checking, particularly where this is around that sort of direct, this sort of misinformation that causes direct effects, has the potential to cause direct effects, helps people correct their false factual understandings about particular issues that have potential for public health harm. The fourth point I'd make is that this isn't a public issue. This isn't only an issue of irresponsible members of the public failing to fact check what they've seen on TikTok or elsewhere. We need greater outreach to policymakers, to the leaders of industry, to health practitioners, because policymakers' false factual understandings are, and I think increasingly will be, a significant part of the problem. And the last point I'd make is that you counter false narratives with factually based narratives. Stories change attitudes in ways that simple facts don't. So I should say this is, I mentioned I'd published a book on this recently. This is a free open source book for which there's no charge. It's not a sales pitch, but what I've said is explained in much more detail there. And thank you very much.